We're now going to move on to our next speaker, Dr. Ian Tucker. Ian Tucker is a well-known urogynecologist based in South Australia. He's been involved in the study, investigation, and management of female urinary incontinence since 1978. In the mid-1980s, Dr. Tucker was seconded by the RANZCOG to establish urogynaecology as a formal subspecialty, a world's first. He's also been a prime mover in the establishment of the Urogynaecological Society of Australasia. He has been a pioneer in neuromodulation of bladder control and has been actively implanting neuromodulation systems for over 24 years. He continues as the Vice President of the Continence Foundation of Australia, is on the Australian Federal Government Urogenital Prostheses and Devices Committee, and is a member of the International Urogynaecological Association, IUGA. PVOGS briefly wanted to thank IUGA for their support today and facilitating Dr. Tucker's attendance. IUGA is dedicated to the global advancement of urogynecological knowledge and patient care through education and promotion of basic and clinical research on disorders of the female pelvic floor. IUGA conduct education programs around the world, develop consensus terminology in the field, connect related professionals, and produce patient education materials. And we encourage you to visit their website to learn more. We'll share this in the chat. Today, Dr. Tucker will speak on complex overactive bladder, including sacral neuromodulation. Thank you, Dr. Tucker.
So, good morning to everyone, and thanks to Katie and the whole crew for inviting me to speak today. And I hope that we can excite you, as VJ, Dr. Roach said, that my journey has been amazing. It's been the most fantastic journey I could ever imagine. It's taken me to all corners of the world, and I've got very good friends in just about every country in the world. And I'd certainly want to encourage you to pursue your dreams, get passionate about it, and get involved in every way you possibly can. It is so rewarding, and I'm sure VJ would attest to that. Today we're going to talk about overactive bladders. It's one of those topics, like a couple of the other topics, that no one ever really wants to talk about. You know, it's one of those taboo subjects, but it's one of the biggest issues in our medical world. And we're also going to talk a little bit about sacral neuromodulation, just more advanced ways of dealing with it. You might wonder what a urogynecologist and who is a urogynecologist. We've graduated in medicine, surgery, and then in obstetrics and gynecology. And then there's a formal training course for the subspecialty of urogynecology. And we deal with fairly advanced aspects of incontinence, of major pelvic floor dysfunction, and so on. And I think there's about 50 in Australia at the moment. So we're a fairly small subspecialty, but hopefully fairly active. And so we're going to talk about complex disorders of bladder function. And some of these slides I'll be glossing over, but you will get the presentation, I believe, given to you. It'll be available, and there'll be more information probably on that than you'll get from me as well. But complex disorders of bladder function just destroy people's lives almost completely. Their ability to work, their relationships, all aspects, and certainly worsen their psychological state and self-esteem. And then you might say, well, what is incontinence? Incontinence is just the involuntary passage of urine. For those of us without a problem, there's not the remotest chance that a drop of urine is going to escape at any time. And so realistically, anyone who's got urine leaking away has a problem. And I'm very pleased that I don't. But I work every day with people who are suffering from this problem. And important aspects of this are to understand something about how the bladder works. And my experience is this is very poorly taught in student days and in young doctor days. The pathogenesis of an overactive bladder, or otherwise known as detrusor overactivity, and all the different possibilities of management, which are considerable, and where we should be going in the future, because we never know enough about anything. We always want to improve our modalities of treatment and expand the horizons. But in Australia, in 2010, there were 4.8 million Australians living with incontinence. That figure would be much higher now because of increased longevity. And in fact, it's one of the major aspects of admission to residential aged care, but it just doesn't affect older people. Those children who wet the bed have incontinence, haven't they? And they will almost invariably have urgency and frequency as adults. A lot of people still don't know that. But looking at the frequency of incontinence compared with other illnesses that you would probably on the surface think would be much greater, you can see how incontinence is one of the biggest issues we have to deal with. And the cost of incontinence, this is back in 1910 when the Continence Foundation commissioned Deloitte Access Economics to look at the economic impact of incontinence in Australia. And again, this would be a lot more now. And the cost was $42 billion a year. If you add in children up the age of 15, it goes to $65 billion a year. There are not many medical problems that come even close to that. So very important. Now you all know about the anatomy, where the bladder is, where the uterus is, where the vagina, the rectum, the vagina. We haven't got that pictured in, but never mind, the vagina is obviously here. Can you see the cursor on the screen?
Yeah.
Doesn't matter much, yeah. Okay. So we don't need to elaborate that, but just remember, we're not born continent. We're all in nappies when we're born, aren't we? And continence is usually obtained by the age of 2.5 to 3 years, and it's not taught. Parents do not train bladders. Continence occurs when the nerve pathways and cognitive function develop sufficiently to allow relaxation of the detrusor muscle on filling and closure of the muscle that holds the urethra closed at the same time during filling. All adults do is really make a mess of it, to be quite honest. But there's a lot of things you probably don't understand about a bladder. This is a bladder that's been taken out of a pig, I think, and put into a physiological solution. Just a little bit of fluid instilled into it to give it some volume. And you'd think it would just stay like that, wouldn't you? But James Gillespie, a very dear friend of mine, who's the Prof of Physiology in Newcastle on Tyne in the UK, he wondered about that. So he did this experiment, and this is what he found. The bladder with a waveform of contractions around it. They're not expulsive contractions, but it's got its own inherent rhythmic contractility. In other words, it's got its own nerve supply. And so, you know, very many really intelligent people like me and Prof Gillespie, believe that if you dare, we spent lots of hours together trying to work out why this should happen. And we're still not sure, but probably if you lose that inherent activity, the bladder's probably never going to work. It's probably something that's necessary for the muscle and the nerves in the bladder to respond to the stimulation from the brain. And just to show you how much detail, oops, that's not how we get this knowledge. We do spend a lot of hours sitting around tables at conferences, and we get much more eloquent when we've had a lot more red wine, as you can see. So in your journeys, just remember to enjoy it, have a good time, and support our state's industries. Along this line, there must be an electrical circuit inside the bladder that is its own inherent electronic activity. And that electronic circuitry, and with nerve pathways being electronic circuits, is fundamental when we come to talk about neuromodulation. And we're not born continent. When we're born, the nerve impulses come from the bladder to the spinal cord in response to distension. When they reach sufficient intensity, they trigger off a knee-jerk type reflex. And so the bladder contracts, the urethra opens, and we wet ourselves. It's all a question, and I'll gloss over these, of when the nerve pathways go up the spinal cord to the brain, the midbrain, the conscious brain, and we compute that, and the brain sends inhibitory impulses down the spinal cord to eventually block the reflex arc so that we gain continence. And so you can see straight away that the integrity of the brain, the spinal cord, the peripheral nerves, the muscular, the anatomy, and the function of the bladder is fundamental if we're going to stay continent. And you can get disorders in all places that will lead to incontinence. Okay, very important. The nerve pathways, though, are a bit like spaghetti junction. You've got parasympathetic nerves, sympathetic nerves, somatic nerves. And we think, well, how on earth do we unscramble that spaghetti junction? And we find that tough. So many different types of nerves, so many different pathways, so many interactions, but they're all critical in the control of bladder and bowel function. And when we're talking about bladder, everything applies almost the same to the bowel. So we talked about those three nervous system. Pelvic floor also has the partial innervation from the somatic. In other words, it's partially voluntary and partially involuntary. That's unusual in the body to have a muscle that is that to that degree a combination of voluntary and involuntary. The parasympathetic nerves stimulate and maintain the contraction of the detrusor muscle of the wall of the bladder, so that's imperative. And do that by releasing acetylcholine. They're involuntary nerves, and when blocked, the bladder contraction may be inhibited. And that's important as well. So let's move on from that. The bladder has these cholinergic receptors, and the M3 receptor is the major one that's responsible for activity that we need to deal with. Sympathetic afferents do basically the opposite. They dampen down the bladder contractility, and they can form a loop reflex. They also help maintain the urethral sphincter. So in other words, they tend towards continence, whereas parasympathetic nerves tend to be involved in expulsion of urine. And then we've got, well, as far as the alpha-adrenergic nerves, I mentioned they can stimulate urethral sphincter, but some of the alpha-adrenergic blockers like Minipress, prazosin, and a blood pressure medication can block adrenergic sympathetic nerves, especially the alpha ones, and they can then block urethral function and cause a lot of incontinence. So these factors are very important when one's considering someone who's presenting with incontinence. So we'll just move down this a bit quickly. And some of these problems that we see in relation to bladder and urethral function, some can be controlled with behavioural techniques, some with pelvic floor exercises and get improvement, some will require medication, and then some are treated surgically with third-line treatments. We'll go into that in a minute. If we're looking at someone who comes along with incontinence, the first thing we need to ask is, how much urine are they making? Every glossy magazine tells people to drink gallons of water. That's the most stupid thing a person can do, basically. That was perpetrated by the Evian Water Company. I hope this is going to get back to Evian. Back in the days when they started selling bottled water. And there's no more substance to that than their monetary gain. Most of us don't drink water during the day. We might have food is all fluid, fruit is all fluid, milk on cereals, teas, coffees. You certainly don't need to drink water on top of that. So the overflowing the bladder is a stupid thing. It's either a bad habit, but if someone comes in and they've got an excessive urine output, which is one, and see someone with incontinence, you also have to think about diabetes. And in the elderly, when they mobilise peripheral edema, that can lead to lots of problems with diuresis at night. And what we need to do for these people is to make sure you do a urine output chart. And that's just a standard sort of urine output chart. You don't need to measure intake because you can't measure intake. Food is all fluid. You can't measure the intake, the amount of fluid in the food they drink. Then you've got teas and coffees that people don't include, all that sort of thing. But you need to know the output. And it should be 1.5 litres in 24 hours, no more than that. Let's look at the next thing, which is bladder storage, because to stay continent, the bladder has to be able to store urine in a relaxed fashion. In other words, one should never have to rush to the toilet. I can assure you, I'm a bit older than all of you by about 3 times. I've never had to rush to the toilet in my life, thank goodness, because my bladder stays perfectly relaxed on filling. But if the muscle of the wall of the bladder, the detrusor muscle, starts to contract when it shouldn't, then that person will have to go too frequently, too urgently, and if you lock the door on them so they can't get into the toilet, they'll be wetting themselves. And an overactive bladder is what we call that, and that is really important. And it presents with frequency, getting up at night, urgency, in other words, having to rush to the loo or else, enuresis, and those kids that have childhood enuresis will almost invariably have urgency and frequency as adults. It may be orgasmic incontinence. It may be post-voiding dribbling. Everyone I see who has an overactive bladder says, oh, they don't empty the bladder either. Well, that's the bladder having a lend of them. Instead of instantly relaxing once it's empty, it keeps pumping away afterwards. So they stand up, go and walk away and think, oh, hell, I've got to go back again, thinking they haven't emptied the bladder. They have. In 90% of cases, it's just the bladder still contracting afterwards. So these are important aspects that you need to find out and need to think about when someone presents with incontinence. There may be incontinence with exertion, even with an overactive bladder, because if you've got a bladder trying to force urine out and you run, jump, cough or sneeze, you may wet yourself. So when you're asking questions to someone, you need to ask the correct questions. Like if you're finding out whether someone's having problems with enuresis and you say, do you wet the bed at night? They might say no. But if you ask them, well, do you wear a pad to bed at night? And they say yes, well, of course they've got enuresis. So not only do you have to ask the correct questions, you've got to ask the questions correctly. And I believe that is across the whole aspect of medicine. 1 in 6 people, we believe, have an overactive bladder like this. So it's a massive problem. And it's slightly more common in males. It's not just a female problem. Okay, more little boys actually wet the bed than little girls. And there are many causes though. It's not just one problem. So it's a syndrome really. But most people that I see have inherited the problem. The genes are we believe are on the 4th, 8th, 13th and 22nd chromosomes. There's probably a couple of others as well. Okay, and the penetrance of those genes will vary from person to person. So the situation or the problem itself will vary from one person to another. Childhood enuresis is basically the same problem. So those kids that wet the bed almost invariably, apart from someone who's got diabetes as a child and that sort of thing, or genetic abnormalities, most of them will have an overactive bladder that they've inherited from their parents or their grandparents. In fact, so poorly understood, this is back in 2012, but that's fairly recent, that there was a guy in court because he was burning his child with matches and a hot knife for wetting the bed. He was probably the one who gave the child the enuresis. So the understanding is still way out there. It's not there. We don't understand it. People in the population don't understand it. But the urgency may come on at any age. It's often there longer than people admit. I had a woman recently who said she'd only had symptoms for 6 months. And I said, really? I said, yes, I've only had this urgency for 6 months. When we were doing her urodynamic studies to find out what was going on, she actually fessed up. She said, actually, you know, my name's Lynn. And I said, yes. She said, when I was at school, they used to call me Lou-a-lot Lynn. She'd had the problem all her life. But people don't want to talk about it. It's really that bad, that important. So it's often associated with urgency with the bowel as well. Never forget that. And there are lots of comorbidities that would impact on it. Diabetes, neurological problems, Parkinson's, in fact, they may cause it, and various medications. But there can be neurological causes. Look at MS, Parkinson's, spinal cord problems, all sorts of things. Infective issues, bladder infections can cause it, tumours, polyps and stones. So we need to think of the whole pathological sieve, but most people I see have inherited. Now, just for your interest, this is a urodynamic study, and the part that we're looking at is this part here where the cursor is. That's under the heading detrusor pressure, and we're filling this person's bladder up. Now, this person we filled to 400, normally stop at 250 initially, but you can see how flat that line is. And the patient felt no urge to go, no desire, no awareness of bladder filling. This is a very normal study. And then we actually look at the pressure along her urethra, and it's a good high top hat type curve. So the muscle that holds the urethra closed is functioning very well. We do a cough profile. If she had what we call genuine stress incontinence, where the urethra is torn away from its supports from childbirth, we would see a negative deflection here, but we don't. And I'm a bit, so there we are. Then we stand this person up and continue, we stood her up and continued to fill to 600. See how flat that pressure is? This person has normal bladder function. Now, clearly, I don't see many people with normal function, but I was fortunate to see this person, so I used it for teaching purposes a lot. Compare this with an overactive bladder. Now see here, there's a rise in pressure in her bladder on filling, and she will have severe urgency and almost certainly, even when we've stopped filling and looking at urethral function, there's bladder function going, bladder contractions going on. Then when we stood this person up, massive detrusor contractions. So this person has an overactive detrusor or bladder, okay? So very embarrassing. If you don't treat it properly, the high pressure in the bladder can retard the drainage of urine from the kidneys. You can damage the kidneys, more likely to get renal calculi, and so on. So very important. If you then have too much urine output into a high pressure bladder, you're really asking for trouble. Okay, how are we going to treat it? Well, the best treatment will be this sort of image where you have optimal balance between efficacy of treatment, minimal side effects, and therefore adherence to treatment over a long period of time. And that's been a problem that we have with treating the overactive bladder, because to treat the overactive bladder, we have to try to get the detrusor muscle to stay relaxed on filling. We can't change the genetics, not yet anyway. So we need to make sure the urine output's normal. We need to reduce the things that are really good in life, like wine and bubbles and things like that. So we've got to be nasty. Pelvic floor exercise to help the ability to hold on, but people with overactive bladders tend to have the best pelvic floors in town because they've had to. We can try and retrain the bladder, however, it's not very effective, and we can use the lowest grade form of neuromodulation, such as a TENS unit. But then the second line treatment is medication, and for many years we've relied on medication, initially poorly with potent with antimuscarinics that have very significant side effects of a dry mouth, feeling lousy sometimes. We worry about the long-term effects on cognitive function. More recently, we've had released a preparation that stimulates the beta-3 sympathomimetics, which are the nerves that, when stimulated, keep the bladder relaxed. So it's a very different pathway. And in practice, we'll often use combinations of medication to control a bladder. But these have changed the landscape of how we control overactive bladders. So, but unfortunately, the side effects of the ones before we had the beta-3 stimulants, adherence to treatment was always a problem. Most people couldn't stand the side effects, so treatment dropped off fairly radically. And mainly due to these side effects which I've mentioned. And mirabegron, I should say, the beta-3 sympathetic that we have, it's the only one of its type at the moment, does have less side effects. We do worry about a slight potential for increased hypertension. And I've had one or two people who've had a hypersensitivity reaction to it with a rash. Unfortunately, it's more expensive, but it's not on the PBS. So what happens if we fail to be able to control with medication? We then have to look at the third line treatments. And the third line treatments sacral neuromodulation, stimulating the third sacral nerve, injection of Botox into the wall of the bladder, or even instilling it into the bladder, what we call percutaneous tibial nerve stimulation, which is stimulating the end of the third sacral nerve, the end branches of the third sacral nerve. So it's a very similar thing in terms of how it works, but it only picks up a fraction of the number of nerve endings. We sometimes have to resort to an indwelling catheter. I've got a patient that I've had to resort to that this week. We try to avoid that if possible. More importantly, we try to avoid major surgery like urinary diversion procedures. So all of the treatment I've mentioned is aimed at more conservative control of an overactive bladder. And so when it comes to neuromodulation, we put a little pacemaker in, down in just below the hip in the back, in the buttock area, and the lead comes around here and goes in to the third sacral foramen. Now, the good Lord knew he had to stimulate the third sacral nerve, so made the sacrum with these little holes in the sacral foramen. Across the holes, internal to the holes, run the sacral nerves, the first, second, third, and fourth. And it's the third sacral nerve that is the nerve that stimulates and really controls or regulates the control of bladder function via the brain and spinal cord. So by stimulating the third sacral nerve, we tend to improve bladder and bowel function. Bear in mind, so many of these patients have a combination of both types of incontinence. Okay, so let's move on a bit. So neuromodulation is the treatment that delivers either electricity or drugs or even magnetic therapy to nerves in order to change their activity. And we function as an the nerve system function as an electronic circuit, and as such, we can modulate the current in that electronic circuit, and that's what neuromodulation does. Sacral nerve stimulation is a means, as I showed you just then, of directly stimulating the third sacral nerve. Whoops, sorry. I've been putting these in for 25 years now. That's quite a while. So you can see it's not actually a new form of treatment, but so many people have never heard about it. It's really strange. They know about putting a pacemaker in to control the heart, but we've been controlling bladder and bowel function with this for 25 years. Neuromodulation is also used for spinal cord stimulation, for pain, deep brain stimulation, a lot of indications these days. Okay, so we'll just move on. And the indications in Australia for the use and practice around the world of these problems, which we've mentioned already, but also for the opposite end of the spectrum, where the person doesn't completely empty the bladder. But also, not approved in Australia for reasons that remain obscure, it is indicated in chronic pelvic pain situations. When we how do we do it? We do it in 2 stages. We do a test phase and then we implant. If it's successful, we implant the pulse generator. And we put a little needle, the person's lying on the operation couch on the bed. Some people do it under local, most of us do it under general with no paralysis. And we put this needle in and guide it under X-ray control. And by knowing with the landmarks approximately where the sacral foramen is, we guide this little needle in and we're able to stimulate that needle, and we should get a nerve response that means pulling up of the anus and perineum and movement of the big toes. The big toes are supplied by the third sacral nerve as well. At the end of it all, when the pacemaker's in, we program that toe movement out. And we need sufficient, and then we put in a temporary lead via a system of trocars and cannulas, and we burrow that lead around to where the pacemaker sits in the buttock. And that's an old pacemaker. The newer ones are much smaller than that. We're about to get even smaller that are rechargeable, but that's not available yet. And that's the way the lead should sit through the sacral foramen when we're looking at a lateral view. And it's actually as easy as a walk in the park. That was walking across the park in New Zealand before the earthquake. And we stumbled across this sculpture and I couldn't resist it. It was too good. So the rep who was with me from Medtronic took the photo and I photoshopped the needle in because it is very straightforward. Okay, it's not major surgery. This is the first lot that I did back in 1995 to 1997. And these were the pre-operative voiding volumes, and these with the pacemaker in. You don't have to be a Philadelphian lawyer to see that's a substantial improvement. And from a lifestyle point of view, that is a massive change in their life. Okay. We do have problems. The lead can move. It can move in or out, and that happens quite commonly, unfortunately. The lead can break. There's a lead that's moved out of it. That's a very old lead, but it's moved out. There's a lead that's moved in, and that's the hard one to retrieve, obviously, because there are little tines on the lead that hold it in place, like a carpenter's wall plate. So once they move in there, it's hard to retrieve, but we can do it. So what I designed with Medtronic, these are the tines that they have on it. Now, if you look at that, it's shaped like an arrow. It stops the lead from moving out, but it doesn't stop it moving in. And we found that thin patients, it tended to move in, probably from direct pressure, and people who are a bit obese, it tends to pull out. So what we did is just change that distal tine going the other way, and that effectively stopped inward migration, which is the hard one to deal with. However, trying to continue to get that lead available has proven difficult, and yet it's the only lead that should be used. Infection can occur like it can in any procedure that involves surgery or implantation of a prosthesis. The lead can break, you can get pain, sometimes you need to take it out, put it back in later. But the success rate when you're dealing with this difficult group of people who have never responded to anything is about 76% long term. So by any stretch of the imagination, that's a pleasing response. We're never happy with that. We're always trying to think of ways of improving that even further. But just about everyone who has it implanted would do it again. And that's where it comes to wanting to maintain that sort of therapy. And we can add medication to that. We can even Botox as well, which we'll come across in a minute. So it is the gold standard at this point in time when conservative options fail. No question about that. Its longevity, its proof of success has been well established. Okay, and if you look at that's very different from the medication chart that I showed you before. Botox. Botox is sexy, isn't it? You know, look at that. This is the before and this is the after. Very common, isn't it? So is it sexy? Because what happens when it goes wrong? There's also been some fillers put in there as well, I think. When it wears off, Botox wears off asymmetrically. So have a think about Botox in your forehead with a plaster cast and wearing off asymmetrically. Yeah, don't even go there. Not pretty. How does it work? It inhibits the release of acetylcholine from the vesicles in the nerve receptors and the muscle junction, and so it blocks the parasympathetic nerve with acetylcholine outflow. Okay, and so basically it blocks those and kills the nerve endings effectively, but they regenerate over a few months. So by 6 months, the symptoms are back. So it has to be done twice a year. Technically, it's very easy, just with a little telescope in the bladder, which is passed, feed the needle along, inject it into the wall of the bladder in 20 spots around the dome of the bladder, just a 0.5 ml in each spot. In Australia, we are allowed to use 100 units. In someone who's not got neurological problems, if they're neurogenic bladder, we can use 200. Okay, is it effective? Well, it is, but it's only about the 50% mark. Okay, so it's nowhere near the success rate of say, neuromodulation. However, it is easy, it is easier. Okay, it lasts for 3 or 4 or 5 months, has to be repeated twice a year. Unfortunately, when Paul Hilton and his cohorts looked at the longevity of the use of Botox, only between 4 and 6% persisted after 4 years. In other words, for some reason, the effectiveness of the Botox isn't sustained as long after each time it's injected. So by 4 years, it's not lasting very long at all. But it certainly is used, and it's certainly handy for an immediate result over a relatively short period of time. For some people, that's a godsend. Okay. Curiously, and this I haven't done enough to get results from it, when I've had a person with neuromodulation and that hasn't worked as well as I'd like, and then I Botox them as well, I seem to get a better result long term than with either individually, but that's too early to produce any data on that. That's the drop off in the use with the Botox. All right. And that's the pie chart, the graph, which looks very similar to medication, unfortunately. And there's no real way of, as far as we know, of improving that unless we use bigger volumes of Botox, but then we'll put people into retention in a greater chance of doing that. Okay. So that's basically what we're going to show you today. A take-home message is that this is a huge problem. An overactive bladder is a massive problem in our society. The first person who had a pacemaker that I put in was a teacher who'd had to give up teaching because she couldn't stand in front of the class without wetting herself. After we put the pacemaker, she'd failed to respond. We only had 1 or 2 medications available in that stage. After we put one in, she went back to full-time teaching 6 weeks later, taught till she was 65, she's now 73 and still temp teaching. So we have the ability these days to make huge changes using the various modalities of treatment. Remember these things, which you'll all get on the presentation anyway. The output chart is so important. Always, if someone comes to see you with incontinence or abnormal voiding function, always get an output chart. Okay, you need to examine appropriately. You look at the various conservative options, and in practice, we use every option we have available. And just because you use one modality doesn't mean you can't combine it with another. And hopefully, in that way, we will improve the outlook for this huge population with these disabling conditions. So I'd like to stop there, and if there's any time, I'm certainly happy to answer questions. I hope I've given you some insight into one of the most common and debilitating conditions that we're faced with.
That was fantastic. Thank you, Dr. Tucker. We probably have time for one question. We have a question from Donna. She asks, what's the ideal patient profile for sacral neuromodulation for overactive bladder?
Yes, well, firstly, they have to have the right indications. There's no question about that. They have to be well aware and understand the situation. Once you put a pacemaker in, you're married to that patient, because they often require reprogramming. They may require lead replacement and so on. So they have to be well aware of the problems. They have to have failed the conservative options. They have to have failed at least 2 medications. And then they have to be medically fit for surgery. And we have a lot of people on anticoagulants, I should say. And clearly we don't operate in the presence of anticoagulants. So we need to use stop the anticoagulants and perhaps use, they're often on one of the more recent anticoagulants. Then we need to stop those sometime beforehand and use some Clexane, short-acting anticoagulant, until 48 hours before surgery, and then resume anticoagulants when we're happy that there's no risk of subsequent post-operative bleeding. So they've got to be medically fit for lots of reasons. Ideally, they should have reasonably good cognitive function. It's very difficult, but in fact, there's one person that the staff thought I'd lost my marbles by doing it, because she did have some early dementia, but she had a very, very good carer. Her husband was totally with it. And when we put the pacemaker in and improved her continence control, her cognitive function improved enormously. She, instead of being disheveled when I saw her, no makeup, just disheveled, she'd come in, hair nicely done, makeup on, looking totally different. And you can't assess that. It's not something you can put in any research protocol, but it's hugely important that we restored her self-esteem and confidence, I should say, as well as continence. So these are the main indications. They're the people that we will do. They've got to have the problems appropriately. They've got to understand it. They've got to have tried and failed conservative treatment, fit for surgery, and they'll need long-term follow-up as well. But usually they're the happiest people you'll ever see.
Thank you. And we definitely all agree that you've been on the frontier of neuromodulation. We thank you for your time today.
Well, it's a pleasure. I just hope I can help motivate people to pursue their dreams and their practicing life, because it is so rewarding.
Thank you.
Okay.